Assalamu alaikum dear students, hope you all are doing well. I am your course instructor Aiza Yousaf for the course of Gerontology and Geriatrics Physical Therapy. Today we are going to learn about depression in elderly population. After today's lecture, you are able to learn how cognitive and psychological changes associated with aging, how depression and other psychological conditions will reduce functional performance in later life, and how it can be assessed and what are its clinical manifestations. And learning through these points, you are able to manage different strategies to overcome depression. Now, first of all, what is depression? It is a mood disorder that causes persistent feeling of sadness and loss of interest. It is also called major depressive disorder or clinical depression. It affects how you feel, think, and behave and can lead to a variety of emotional and physical problems. You may have trouble doing normal day-to-day activities if you are suffering from depression. In simple words, depressive patients are mostly pessimists. Pessimists who have always think about negative vibes. Depression is the most common psychological problem in the elderly, as well as it is the most neglected condition also. Its prevalence is about 4 to 23% in the elderly population. It causes loss of health due to stress of physical illness, or it may be associated with physical disability. It may cause fatigue, generalized pain, lifestyle changes. Psychosocial response of depression dramatically affects the patient response to rehabilitation. As patient is not feeling well, patient is always in the state of anxiety. That's why he is not capable of giving response, a better response towards the treatment. Depression makes a rehabilitation or any treatment a bigger challenge. It causes apathy, hopelessness, withdrawal. They constitute a problem that physical therapists must deal with frequently. Modifications of the physical therapist treatment plan that are appropriate for a depressed elderly patient according to her needs and demands, as the state of depression is different for every individual. There are different characteristics of depression. Some are given below. Number one is mood, feelings of sadness, mood. In mood, feeling of sadness, hopelessness, and loss of interest and pleasure in previously pleasurable activities. In the domain of cognitive difficulty, a patient may feel difficulty in concentrating, memory complaints, slow thinking, indecisiveness, unable to make decisions, and perceived lack of competence and control. Patient may feel low self-esteem, maybe feel like worthlessness, decreased motivation, apathy, and excessive guilt. Patient may feel difficulties with interpersonal interaction, withdrawal from family and friends, and neglect previously pleasurable activities. It may show somatic functions like pain or generalized weakness. A decreased appetite, loss of weight may involve excessive eating. In the domain of sleep, may cause insomnia and early morning awakening, and may also cause hypersomnia. As I have said earlier, that depression for individual person represent its clinical symptoms differently. For some patient, it may cause loss of weight due to decreased appetite, or in some other patient, it may cause increase in weight due to increased appetite. And in some patients, it may represent as insomnia, lack of sleeping, or early morning awakening. Or in some patients suffering from depression, it may cause hypersomnia, excessive sleeping. All depends upon the personality traits of individuals. Psychomotor function may be retarded or may be agitated. So diagnosis, they are different according to terminology. It have two different types. We can use DSM diagnostic and statistical manual for diagnosis of depression. And according to American Psychiatric Association, there are two most important diagnoses for depression, which are following. Number one is major depressive episode, and number second is adjustment disorder with depressed mood. So now we are going from these diagnoses one by one. What are the major traits of individual diagnosis? Major depressive episode. It represents depressed mood and markedly diminished interest or pleasure in all or almost all activities. May cause weight loss or weight gain when not dieting, or increase or decrease in appetite, depending upon the individual's habits. It may cause insomnia in some patients, or it may cause hypersomnia in some patients. It may cause psychomotor agitation or retardation, or it may cause fatigue or loss of energy, lethargy, etc. Other traits include feeling of worthlessness or excessive or inappropriate guilt, diminished ability to think or concentrate, or indecisiveness, as patient is unable to concentrate or focus on some goals, so that's why it may lack the ability to take decisions. Recurrent thoughts of death, recurrent suicidal ideation, as suicide attempts or a specific plan for committing suicide. Now, the second one is adjustment disorder with depressed mood. As the name represents, there are emotional or behavioral symptoms in response to an identifiable stressor occurring within 3 months of the onset of the stressor. It may represent as increased distress, that of the expected outcome. It may clinically significant symptoms or behaviors as evidenced by marked distress that is in excess of what would be expected from exposure to the stressor. Significant impairment in social or occupational functioning occurs in patients who are suffering from adjustment disorder with depressed mood. Now, here, till now, we are going through what is depression, what is its characteristics, and how we diagnosed in two different domains. And now, what are the major examination protocols or assessment protocols for the depressive patient? The diagnosis is majorly based on history, observation, and careful interview of the patient and close family members and friends. There are some self-reported scales for or good screening devices for depressive patients. As we have done our group projects for geriatrics subject, and in which we have gone through some questionnaires, either performance based or self-reported, for the term or for for the assessment of fall balance. Same as there are some self-reported questionnaires for the assessment of depression, like back depression inventory, which consists of 21 questions, CSD, Center for Epidemiological Studies depression scale, which consists of 20 questions, then geriatric depression scale, and then some self-rating depression scale, which consists of 20 items a year. The geriatric depression scale have done earlier by you people in the case projects. Now, there are some different models of depression which also may be used in the procedure of assessment. There are five models of depression. Number one is cognitive model. Number two is the learned helpless model. Number three is the interpersonal model. Number four is the neurobiological model. And number five is the social resources model. Now we are going. We take a look from them one by one. Number one is the cognitive model of depression. It is the model with the most observed evidence in the treating depression. This model is the most frequently used model for the treatment as it states one's cognition, habits, and beliefs which determine behavior and emotion. So it directly hits the person's sentiments, anxiety, which tackle depression. Aaron Beck is the American psychiatrist, and it is the name which is mostly associated with the cognitive causal model of depression. It pays uh, uh, it contributes in the development of cognitive theories or cognitive model of depression for the treatment of depressive patients. Now, the second model is the learned helpless model. It, as the term specifying an organism learning to accept and endure unpleasant stimuli and unwilling to avoid them even when it is avoidable. As the name represents, learned helpless, that patient learned that there is no hope, and patient thought thinks about that he is unable to do anything to avoid such depressive circumstances. If it does not he thinks about that it does not have any control over the situation, and that whatever he does or does not to do will not have any effect on the outcome, meaning a patient is totally hopeless in this model. Number three is the neurobiological model. Neurobiology of major depressive disorder have traditionally focused on the monoamine neurotransmitters like serotonin and norepinephrine. As we have discussed in the Alzheimer's disease, that neurotransmitters have a major role in brain disorders, just like depression. Just like in depression, different neurotransmitters, especially serotonin and norepinephrine, which are monoamine neurotransmitters, have major role in the depression disorder. This hypothesis initially stated that depressed individuals are likely to have low level of these neurotransmitters because antidepressant drugs, which may used acutely, increase their levels. Even though monoaminergic antidepressants are generally used for the first-line treatment, they do not exert their clinical benefit immediately, and for some people, they do not provide any benefit at all. There are some factors which are associated with depression and may predispose the depressive condition, like any presence of illness. If there is a high level of pain, it may also cause depression. If there is a patient is dependent on others due to some physical disability, it may cause depression. If there is a disease with worse symptoms or with increased severity, it may cause depression. Other psychosocial factors include low income or decreased social support may also increase depression. According to its different diagnosis types, we have different management which is more effective according to its role. Like pharmacotherapy, in which patient is taking medicine. Psychotherapy, there are some behavioral or mood therapies, and then the third one is exercise therapy. Pharmacotherapy has major contribution in the treatment of major depressive episodes, the most common approach of treatment for them. Psychotherapy is the most common treatment approach for the adjustment disorder with depressed mood, while exercise therapy has limited research and it is of particular interest for physical therapists. Now, pharmacotherapy. There are five major drugs categories which may be used in the treatment of depression. Number one is selective serotonin reuptake inhibitors, tricyclic or tetracyclic antidepressants, hydrocyclic antidepressants, serotonin or norepinephrine reuptake inhibitors, and monoamine oxidase inhibitors. These are antidepressants which may be used for the treatment of major depressive episodes. Now, psychotherapy, which is the major front line of treatment for the adjustment disorder with depressed mood. Older patients are less likely to take psychotherapy due to ageism. As we have discussed in our previous lectures, that health professionals may be biased against older persons in that they believe that elders will not benefit from psychotherapy. Research shows that psychotherapy is an effective treatment for depression in elderly. Psychotherapy treatment for elderly include behavioral, cognitive, and brief psychodynamic therapies. Now we will take a look at what is behavioral, what is cognitive, and what is psychodynamic therapies. In behavioral treatment, it may focus on modifying the behavioral components of depression, while in cognitive approaches, we attempt to change the negative schemes that accompany depression. While psychodynamic therapists focus on the personality characteristics for the enhancement of its patient characters towards positive attitude. Now, the last one is the exercise, occasionally used as an effective treatment for depression. Exercise, there is a limited evidence on what exercise play a role on depression. That's why exercise will be occasionally, rarely used for the effective treatment for depression. Research shows clear relationship between depression and physical activity, while it has limited use of exercise as the treatment of depression. Vigorous aerobics improve depression. Mild recreational activity will be associated with increasing feelings of well-being. Time out from periods of psychological stress, increased social interaction, increased feelings of mystery. It may increase secretion of amines, antidepressant effects, induce adrenaline response, which may help in sleep regulation and improve symptoms of depression. Exercise is not commonly accepted treatment for treating depression either. It has a role in treatment of depression. So, how can we work with depressed patient? How can we make a treatment plan or rehabilitation plan for such patient? We can make short-term goals for depressive patient, emphasizing achievement rather than pleasure, so that if they focused on achievement, um, uh, they may lose, they may forget about uh, apathy or hopelessness, and they should avoid excessive carefulness, as if they are more careful and if there will be little negligence, they will be get depressed as soon as possible. And we should assess and treat the patient in his own time, so that patient may feel relaxed. Thank you so much. Here, this is all from our today's lecture. Hope you find it easy and you will get all the concepts. But if you find any query or you have any question, then note it down. We will discuss it in our interactive session. Thank you. Take care. Allah Hafiz.